The two gold standard therapies for advanced Parkinson's disease, levodopa and deep brain stimulation, eventually induce severe, erratic complications. The treatments engineered to restore movement actively become the cause of intense motor fluctuations and dyskinesia. In pharmacology, this occurs because oral medications operate in an open loop. A patient swallows a pill, creating a massive chemical peak in the bloodstream, followed by a steep crash, completely blind to the real-time state of the brain. Conventional deep brain stimulation applies this same open-loop logic to electrophysiology. Improvised electrodes bombard neural networks with a constant rate of electrical pulses, regardless of the circuit's actual momentary activity. The biological reality of the basal ganglia stands in direct opposition to this methodology. The basal ganglia operates as a highly dynamic, responsive, homeostatic biological network, continuously adjusting signals to maintain perfect equilibrium. Forcing a static, rigid intervention into a dynamic biological network produces toxic results. The chemical mismatch yields levodopa-induced dyskinesia, while the electrical mismatch triggers overstimulation side effects like forced muscle contractions and speech impairment. Preventing these complications requires abandoning static interventions entirely. Clinical neurology is now transitioning to closed-loop systems, continuous dopaminergic stimulation, and adaptive DBS. Iatrogenic movement disorders are a direct consequence of non-physiological delivery parameters, rather than an inevitable disease progression. The mechanical failure of oral L-Dopa begins with its pharmacokinetics. The drug has a severe biological limitation, a short half-life of less than 90 minutes. This line graph maps how that short half-life translates into sharp, recurring spikes in L-Dopa blood plasma concentration, followed by rapid crashes after every single dose. Over a 5-year timeline, the physical progression of the disease narrows the brain's therapeutic window. The fixed plasma spikes are eventually forced directly into the dyskinesia threshold. Moving from the bloodstream into the severely denervated striatum, the structural damage is profound. The brain lacks the normal dopaminergic terminals required to smoothly uptake this exogenous L-Dopa. To compensate, intact serotonin terminals take over the job. They absorb the exogenous L-Dopa and release it into the synaptic cleft in a chaotic burst. While serotonin terminals are fully capable of converting L-Dopa into dopamine, they completely lack the D2 autoreceptors required to regulate dopamine release and clearance. Stripped of this autoregulatory machinery, every oral dose of L-Dopa is transformed into a massive, unregulated dopamine surge bombarding the synaptic cleft. The combination of the drug's short half-life and this unregulated serotoninergic release creates a violently pulsatile chemical environment, rendering normal motor signaling impossible. That pulsatile environment causes severe downstream damage to the postsynaptic medium spiny neurons of the direct motor pathway. Years of severe dopamine denervation induce extreme receptor supersensitivity in these D1-positive neurons, priming them to overreact to any stimulus. Looking at this intracellular schematic, we see the immediate reaction when pulsatile dopamine floods these supersensitive D1 receptors. The activation triggers a hyper-illuminated CAMP cascade that forcefully halts phosphatase activity inside the cell. This drives the canonical pathway into overdrive, specifically causing the hyperphosphorylation of the DARP32 protein at threonine 34. Simultaneously, the surge triggers the aberrant recruitment of the non-canonical ERK12 signaling cascade, which branches off directly from the primary D1 activation. These overactive ERK12 molecules cross the nuclear membrane, entering the nucleus to trigger persistent gene transcription. Inside the nucleus, this pathway selectively and persistently upregulates the specific transcription factor delta FOSB. The dense accumulation of delta FOSB commands the overexpression of prodynorphin, locking the corticostriatal synapses into a state of pathological potentiation. Levodopa-induced dyskinesia is an iatrogenic epigenetic rewiring of the striatum, triggered exclusively by the pulsatile nature of the drug delivery. The pharmacological solution to this pulsatility is continuous dopaminergic stimulation, or CDS. In clinical practice, this is achieved through interventions like levodopa-carbidopa intestinal gel. Continuous intestinal infusion physically flattens the pharmacokinetic curve, permanently eliminating the peaks and troughs of oral dosing. This dual-axis chart maps the direct molecular consequence of stripping pulsatility out of the striatal environment. As the continuous drug delivery holds steady on the bottom axis, the accumulated delta phos-B levels on the top axis slowly decay, dropping back down to baseline. This continuous state successfully normalizes indirect pathway overactivity while avoiding the activation of the direct pathway markers responsible for dyskinesia. The network also experiences secondary benefits, primarily the rapid dampening of neuroinflammatory glial markers like TNF-alpha and interleukin-1 beta in the basal ganglia. Transitioning a patient to continuous chemical delivery proves that stripping pulsatility from the environment actively reverses established maladaptive neuroplasticity. Pivoting to the electrical parallel, conventional deep brain stimulation operates on the same fixed parameter flaw. Because the voltage never changes, static DBS blindly causes dyskinesia through severe overstimulation during a patient's clinical on periods, and permits rigidity through understimulation during their off periods. To build adaptive DBS, a system that reacts dynamically, engineers had to find a reliable, real-time biomarker in the brain to close the feedback loop. They found it in local field potentials. These are the summed synaptic currents of local neuronal populations, measured directly off the implanted DBS electrode itself. This waveform diagram shows raw neural data passing through a filter, isolating out a clean, oscillating sine wave. This specific frequency is the 13 to 30 Hz beta band, located within the subthalamic nucleus. By isolating this frequency, neurologists established an exact clinical correlation. Elevated beta power scales in perfect synchronization with the physical severity of bradykinesia and rigidity. The ADAPT-PD closed-loop algorithm reads this beta activity on a millisecond scale, allowing the device to react instantly. It operates on an inverse response mechanism. As the pathological beta band amplitude crosses a personalized threshold, the device automatically scales up electrical stimulation to suppress it. As the neural activity normalizes and the beta drops, the device executes a fade-out response, withdrawing the stimulation. This explicitly prevents electrically induced dyskinesia. By binding electrical output directly to real-time neural fluctuations, adaptive DBS completely eliminates the static over- and understimulation trap. This blueprint schematic illustrates how managing advanced Parkinson's has become an exercise in engineering homeostasis. The next generation of adaptive DBS software will track multiple biomarkers simultaneously. This includes analyzing gamma bands to detect the onset of dyskinesia and theta-alpha bands to monitor cognitive states. External wearable sensors tracking movement and sleep metrics will eventually feed directly into these internal algorithms, enabling highly predictive machine learning models. Equipped with this combined data, these predictive algorithms could adjust stimulation parameters minutes before a pathological fluctuation even manifests clinically. The future of advanced Parkinson's intervention lies in perfecting continuous, closed-loop delivery of tools we already have, rather than searching for new agents.